All right, let's get right into it. Today, we're cracking open the skull, figuratively of course, to understand how the brain systems work. Why? So when you're on a scene with a confused patient, you know what you're looking at. This is all about recognizing injury patterns when every second counts. Every time you deal with a patient who has an altered mental status, you're not just seeing confusion. You are watching, in real time, the breakdown of a specific, complex system. You're on the front lines, getting a front row seat to the intricate machinery of the mind as it fails.
So here's the million-dollar question, right? Which system is actually going down? Is it a memory problem, a reasoning problem, or is it something much deeper, something that's an immediate threat to their life? Knowing the difference can completely change how you manage that patient. That's what we're here to do, give you a framework to make that call, right there on scene.
Okay, I get it. You might be thinking, why do I need a neuroanatomy lesson when I'm focused on skills? But here's the thing. Understanding the why behind what you're seeing makes every single thing you do faster, sharper, and way more effective.
Look, this isn't just some textbook theory. This is street-level knowledge. This is what helps you tell the difference between a patient who's just lost their short-term memory and one whose judgment is so impaired they're about to make a fatal mistake. It's what lets you turn to a terrified family member and say, this is the injury talking, not your loved one. This is the foundation for everything. To make this really simple, I want you to think of the brain like an onion. Seriously, it's got layers. The stuff on the outer layers is all about complex functions, quality of life things. But as you peel back those layers and go deeper toward the core, the functions become absolutely critical for life itself. So that outer layer, that's your cerebral cortex. Think of it as the brain's C-suite. It manages all the high-level voluntary stuff. When it's working right, you get smooth, coordinated movement, clear speech, logical thoughts. But when it's injured, maybe from a stroke, you'll see things like one-sided weakness or confusion. It's a huge problem, for sure, but it's an issue of quality of life. The patient is usually still with us. Now let's peel that first layer back. We're in the middle now, in the limbic system. This is the brain's emotional core and memory maker. When it's healthy, emotions are stable and you can make new memories. But if it gets damaged, you're looking at wild mood swings, personality changes, or the classic, who are you, where am I, scenario. It's serious, but it's not typically an immediate threat to life.
And now, we get to the very core, the brainstem. And let me be clear, this isn't about quality of life anymore. This is about life, period. This little piece of hardware controls the absolute basics: breathing, heart rate, consciousness. If this area gets hit, you're going to see it immediately. Loss of consciousness, crazy breathing patterns, vitals all over the place. This is the ultimate emergency.
So, it really is that simple. The deeper the injury, the more dangerous it is. When you're assessing a patient, use this onion model in your head. Are the signs pointing to an outer layer problem, or are you seeing red flags for an injury to the core? It's a quick and dirty triage tool that works.
Okay, let's shift gears for a minute. We need to talk about how information even gets into the brain. This is so important for how you talk to an injured patient, and it all comes down to what we can call the small door problem. For you to remember anything at all, it has to take this exact journey. First, new information has to squeeze through the very narrow doorway of attention. Then it lands in the tiny sorting room of working memory, where it gets processed. If it's important enough, the hippocampus acts like a long hallway, moving it to the giant archive of long-term storage. If there's a breakdown at any point in that chain, learning just stops. It fails.
So what does this mean for you on a scene at 3 a.m.? It means you have to respect that tiny little door of attention. You can't just throw a bunch of instructions at your patient. You have to chunk it, one simple command at a time. Squeeze my fingers. Good. Wait. Now can you tell me your name? And here's the most important part. If they don't do what you say, don't assume they're being difficult. Their whole processing system is probably broken. It's an inability, not a refusal.
Okay, this next part is absolutely crucial for your field assessment. You have to understand that memory and reasoning are two totally separate systems in the brain. They can fail on their own, and when they do, the patients look completely different.
And this is where things get really tricky and honestly pretty dangerous. It's a cruel paradox. The part of the brain that's supposed to say, hey, something is seriously wrong with me, the frontal lobe, is the very part that's injured. So the patient literally cannot recognize that they have a problem. They are often completely, totally, and confidently unaware of how bad things are. So let's put these two patients side by side.
On one hand, you've got the patient with memory failure. They're confused, but they're usually cooperative. They know something's wrong, and they keep asking, what happened? Now look at the patient with reasoning failure. They're the exact opposite. They are confident, but they are dangerously impaired. This is the person who insists, I'm fine, while trying to make a decision that could get them killed. One is confused, the other is a hidden danger.
All right, let's bring it all home. How do we take all these concepts, the onion, the small door, the two systems, and turn them into a practical tool you can use on your next call? It all boils down to connecting what you see to where the problem might be.
Think of this as your mental cheat sheet. Your patient keeps asking the same question over and over. Your brain should immediately go hippocampus. You see sudden weakness all down one side, you're thinking motor cortex. The patient who fell has a giant gash on their head but swears they're fine to drive home. That's a massive red flag for a prefrontal cortex injury. And of course, if you see that irregular breathing and they're unconscious, you know you're dealing with the brainstem. That's the big one.
And that's the bottom line, right? You don't have an MRI in the back of your ambulance. Your job is not to come up with a final definitive diagnosis. Your job is to be an expert pattern recognizer. Seeing those patterns early and acting on them, that's what saves brain tissue. That's what saves lives.
So let's just hammer these points home one last time. Remember, the brain is layered. The deeper, the deadlier. Remember, learning has a tiny door, so keep your communication simple. Remember that reasoning and memory are two different things. And remember, every symptom you see is a clue pointing to a location. Your job is to see the pattern.
So, the next time you step out of that rig and walk onto a scene, this is the question to have front and center in your mind. You are the first line of defense for the most complex organ in the known universe. You're not there to diagnose, you're there to recognize. What pattern will you be the first to see?